Hello and welcome to my lecture on somatostatin receptor imaging with 68 gallium dotate PET CT. This is a lecture only for teaching purposes, and my acknowledgements are in the next two slides. I have taken extensive help from these two articles, excellent articles. One is by Hoffman et al., and this is entitled somatostatin receptor imaging in radiographics, and the next article is from the Journal of Nuclear Medicine, Current Concepts by Bodei et al. About 68 gallium dotate. So a brief introduction about neuroendocrine tumors. Neuroendocrine tumors constitute about 0.7% of all malignancies in the United States, and their incidence is increasing at the rate of 3 to 10%. Now, a majority of them, about 66%, arise in the gastropancreatic area, and about 25% occur in the lungs. Now, the prevalence of neuroendocrine tumors as a gastrointestinal cancer is exceeded only by colon cancer. And there are less common neuroendocrine tumors such as pheochromocytoma, paraganglioma, medullary thyroid cancer, and neuroblastomas. Now, the WHO classification of gastroenteropancreatic neuroendocrine tumors is based on the morphology and Ki-61 scoring index. They are divided into three. G1 Ki-67 is less than 2%, then G2 where it is 3 to 20%, and then G3 which is more than 20%, and this is a mixed adeno-neuroendocrine carcinoma. I will be talking a little more about this later. Just wanted to give you a brief introduction about this topic. Most of the neuroendocrine tumors are either G1 or G2, and they are well differentiated. Only about up to 8% are G3 with a Ki-61 of more than 20%. Now, even amongst the G3 group, they are divided into two groups based on their different clinical behavior in response to treatment. One is the G3, which is differentiated type, where the Ki-67 index is between 20 and 50, and then G3, which is poorly differentiated with a Ki-67 score of more than 50%. A brief word about indium octreoscan, which was the first agent that was approved for neuroendocrine tumor imaging, and then subsequently the gallium-68 labeled agents with PET CT. They are much better because they provide better resolution and quantification. There are three agents that have been found useful, and they are similar in almost all respects. Now, two of them have a higher affinity for somatostatin receptor 2, whereas the Dotanoc has affinity for somatostatin receptor 3. Now, despite these differences, there is no agent which is better than the other, so they all have similar activity and usefulness. Now, 68 gallium dotate is a radiolabeled somatostatin receptor imaging agent which is used for PET or PET CT for localization of somatostatin receptor positive neuroendocrine tumors in adults and pediatric patients. And it is not only used for staging and restaging, but also for selecting patients for peptide receptor radionuclide therapy, PRRT, with either cold, which is non-radioactive, or radioactive labeled somatostatin. Well, I mentioned that the gallium agents are better than the indium labeled agents, and FDA has approved 68 gallium dotate for localization of somatostatin receptor positive neuroendocrine tumors in both children and in adults. Now, when we prepare these patients for scanning, there is no consensus whether the somatostatin treatment should be withdrawn. If it is possible, discontinuation should be done, and short-acting analogs should be stopped for at least 48 hours, whereas for longer-acting formulations, 4 to 6 weeks would be the ideal. Now, the data that has investigated the impact of somatostatin on gallium dotted PET CT in the same patient studied on and off treatment for 2 consecutive days do not support the need for discontinuation. However, there may be some reduced uptake at physiological sites with unchanged tumor uptake, resulting in higher contrast. But despite this evidence, since normal organ and tumor uptake tends to increase the later the PET scan occurs after somatostatin administration, many centers would scan patients at the end of somatostatin treatment cycle if possible. So obviously, despite lack of evidence and lack of consensus, most centers would prefer that either be discontinued or it should be done at the end of the somatostatin treatment cycle. Typically, we'd use a dose of 2 megabecquerels per kilogram body weight, which amounts to 0.0554 millicuries per kilogram, up to 5.4 millicuries. This is given as an IV injection, a bolus injection. The amount needs to be verified, and the dose should be within 10 plus minus 10% of the recommended dose. You cannot exceed the dose, and the patients are encouraged to drink water before and after the injection and to void frequently, which is a sort of instruction that we give to more or less most of the patients who come to nuclear medicine. Now, PET CT acquisition typically begins 45 to 60 minutes after the injection, and you start scanning from the top of the skull to the thighs. Um, Now, the clearance of this agent from blood is rapid and it has a bi-exponential elimination, and radioactive metabolites are detected in serum and urine in the first 4 hours, and maximum activity of the tumor is reached in 70 to 20 minutes, or meaning 90 to 50 minutes in that range. Um, Excretion is by kidneys, and physiological uptake is high in areas where there is somatostatin receptor 2 rich organs such as the pituitary, spleen, adrenal, liver, kidney, pelvocalyceal system of the kidneys, and the urinary bladder. Low uptake is seen in the thyroid, in the pancreatic head, stomach, small and large intestine, and prostate. Um, Here is an example of a normal biodistribution. Normal uptake is taken in the pituitary, in the liver, in the spleen, in the kidneys, in the ureters, urinary bladder, and also in the thyroid and the GI tract. Um, the highest dose of radiation is in the spleen and the urinary bladder wall. Um, so now the gallium-68 DOTA, or GAT8 PET CT is the technique for detecting and characterizing the neuroendocrine tumors. Um, in the past, it was accorded orphan drug status by the FDA. Now, this is a useful agent for multiple tumors, including gastrointestinal, pancreatic, and bronchial neuroendocrine tumors. Additionally, pheochromocytoma, paraganglioma, meningioma, oncogenic osteomalacia is also an indication. False positives can be seen in um, areas like uncinate process of the pancreas, also anywhere there is infection, inflammation, osteoblastic activity, and splenosis. So I will give some examples of that. Now it has been found out that the FDG F18 FDG PET CT is complementary to the gallium Tate PET CT for evaluation of poorly and well-defined, well-differentiated disease. Now, this agent, along with FDG PET, allows identification of many tumors because the tumors are not of one type. There is heterogeneity, and then in combination, these two imaging modalities provide prognostic information and can be helpful in guiding therapy. Biopsy, I beg your pardon. So optimal patient management includes, theranostic application of the peptide receptor radionuclide therapy, and it is very useful in restaging of patients following therapy. I will be repeating some of this information. I want to talk briefly about somatostatin receptors. These are present on the cell surface of the neuroendocrine cells, and this provides us a unique opportunity as a molecular target. And Now, somatostatin has some inhibitory effect. It suppresses the release of pancreatic hormones and reduces smooth muscle contractions. Now, octreotide is a synthetic somatostatin analog. Half-life of octreotide is only 90 minutes. Half-life of somatostatin is 2 to 3 minutes. And octreotide labeled with the indium, or we have used in the past with a gamma camera. So, in case of Octreoscan, 10 micrograms of octreotide is radio labeled with indium 11 injected, and then we do planar imaging and SPECT imaging at 24 hours. If needed, do delayed imaging at 48 to 72 hours. And perhaps because of the availability of SPECT CT, need for delayed imaging has been obviated. There's no need to do that now. Um, on the other hand, now we have the ability with gallium 68 SPECT PET CT. We have so this agent has replaced indium 111 octreoscans scans because it provides better detail and it is speedier to do that, allows better detailed anatomic information. Another advantage is that it is generator produced. The 68 gallium is generator produced positron emitter that you can allows on-site demand availability. It has only a half-life of 68 minutes compared to 2.8 days for indium, so radiation dose is much less. And the other thing is that it can be performed 45 to 60 minutes after the radio tracer injection, which was not the case with the indium agent. So I mentioned there are three uh, agents that are available, or analogs that are available: dotate, dotatok, or and dotanok, gatok or ganok, and gatate. So they have not found any advantage of one versus the other. Highest physiologic uptake of gatate is in the spleen. This is followed by adrenals, kidney, and pituitary, also in liver, salivary glands, and thyroid gland. And uptake in liver and kidneys is not mediated by expression of the somatostatin receptors. This is a small peptide that is filtered through the glomeruli and it is partially reabsorbed in the proximal convoluted tubules. So that is why there is high activity in the collecting system, bladder, and renal parenchyma, but variable activity in small intestine, large intestine, and stomach. Gallbladder activity is rarely seen, unlike in octreotide, and probably it is related to the earlier imaging, so there is no time for the hepatobiliary excretion to happen by that time. Pathologic uptake grading is based on the scaling scale that we use is 0 to 4, which is based after Eric Renning's. We use the liver and spleen as the reference organs. And compared with the FDG PET, minimal background activity in soft tissue and muscle, which contributes to high tumor to background contrast at pathologic sites. Now, low background and high tumor uptake also contribute to a sink effect, so that the physiologic uptake in the spleen and liver is reduced in patients with a high burden of disease. Um, I'm going to give you some examples. Here's an example um, where a patient had a small intestinal neuroendocrine tumor, and they found a metastatic lesion in the right femur. Um, Obviously, additional areas of metastatic involvement shown by arrows. There is involvement in the chest, also in the abdomen, mesenteric and pelvic nodes were involved. And as we can see, here's a PET CT, which is showing uptake in the femur, and then also in the pubic bone and also in the vertebra. So multiple new sites were found, and obviously, when you have all these extra sites, the therapy changes. So the unexpected soft tissue and bone metastases were detected, and instead of doing surgery and octreotide, the plan was changed to surgery, octreotide, and then selective radiotherapy of the bony metastatic lesions. Here is an example of an ileal neuroendocrine tumor, which is shown by this single arrow. And then there was an additional site which shown by two arrows. And based on the PET CT, we found out that this was only uptake in the right ureter and a physiologic uptake. So no further treatment based on this was required, meaning um, we know that this is only confined to the ileum and not any additional site. I mentioned about the grading, which is 0 to 4, 0 none, no uptake, 1 is very low, 2 is less than that of equal to liver, 3 is greater than liver, and 4 is greater than spleen. Now, you must remember that neuroendocrine tumors are not of one type, but they are a heterogeneous group of disorders, and they can be very indolent to very aggressive. Both of them, meaning the aggressive and the indolent, have the propensity to metastasize, and some of the indolent tumors can cause morbidity because they secrete hormones. And these hormones have a number of clinical syndrome and side effects, such as carcinoid syndrome and then hypoglycemia because of insulinoma and, of course, gastrinoma, which may cause multiple ulcers. I mentioned about the grading system. So the European Neuroendocrine Tumor Society and WHO have established this grading system, which is based on immunohistological staining of Ki67 protein, which is a marker of cellular proliferation. And then based on this, we have three grades, which is K67 less than 2%, 3 to 20%, and then more than 20%. So the more this number is, the higher the grade of the tumor is. Um, Now, PET CT by using gallium is better than CT or MRI alone or octreotide SPECT CT with a specificity and sensitivity in the range of 90s. So it has become the new standard or reference. Extraordinary target to background ratio. You can detect subcentimeter lesions, and the higher contrast of the lesions is reflected in high standardized uptake values or SUVs. Um, so it is the first line diagnostic imaging modality for patients with tumors of which have high somatostatin expression, like gastrointestinal and pancreatic neuroendocrine tumors. And this agent, this PET CT scan can identify additional sites of disease before curative surgery can be planned. Here is an example of a person who had an indium scan, which shows a left supraclavicular node. Following this, 4 days later, they repeated the study with the PET CT using gallium, and you see how many additional new sites have been identified besides this supraclavicular lymph node, which was only visible on the indium study. Here's an example of a FDG PET image, which clearly shows a pancreatic primary tumor. And then, of course, there are hepatic mets. Same thing when you look at the arterial CT imaging, um, you can only identify these lesions in retrospect. I'm comparing it to this, where you can clearly see them, whereas here they were not that easily visible and they had to be retrospectively looked at again. Now, I mentioned that these somatostatin receptor imaging is helpful in detecting disease sites and also characterizing the lesion in terms. And we found that excellent correlation is there between the SUV at gated PET CT and the SSTR expression. So it's an outstanding non-invasive technique for imaging the somatostatin expression. Um, but the expression of somatostatin is variable and it is decreased in poorly differentiated subtypes. So this is something to keep in mind, because FDG PET um, can be positive in poorly differentiated subtypes, whereas the gallium Tate is positive in well differentiated ones. And so, depending on the avidity of the uptake on gallium Tate PET CT images, contrast enhanced MRI can be more sensitive for detection of sub-centimeter hepatic metastasis. And MR imaging is particularly useful in patients who have limited hepatic disease at gallium Tate PET CT who are deemed to be surgical candidates. Now, I'm kind of repeating some of the things I've already talked about, some of this, but basically, gastrinomas are located in the duodenum and stomach. Insulinomas 50% express SSR, the somatostatin type 2 receptor. Um, Now, the ACTH secreting carcinoid tumors are often located in the lung, which is an example of a functional tumor which is picked up by this agent. Um, and so it has a high detection rate for multiple endocrine neoplasia or MEN syndromes. Now, here's an example of a patient who had epigastric discomfort, vomiting, and weight loss. So, we found on gastroscopy duodenal ulceration, high gastrin levels were improved, were symptoms were improved with proton pump inhibitor, and on MR there was 1 centimeter nodule in the mid pancreas. Octrear scan concurred with this finding, and so the patient underwent distal pancreatectomy and splenectomy, but pathology showed benign fatty lobules. So post-op, a PET, gallium PET was ordered, and it shows two focal abnormalities. So again, this sort of re-emphasizes the point that PET allows confident localization of the primary tumor. Here in this case, it is at the junction of the third and fourth portion of the duodenum, and this can be better seen in this example where you can see the primary site. Now, this case highlights the non-specificity of anatomic imaging even when an abnormality is detected, and so gallium Tate PET CT is extremely helpful in this regard. Um, Here's an example of a patient on a gallium Tate PET CT shows a small pedunculated mass with intense uptake arising from the uncinate process of the pancreas. The arrow shows that, and on the CT image, uh, the arrow is showing the tumor, and here's the SMV. So now when we do the PET CT, see how this tumor is lighting up, and gives you a very confident diagnosis of a small mass with intense uptake arising from the uncinate process. The same case, the tumor is this lesion here, and now when you use the PET CT, here is the insulinoma, here's the SMV, and the uncinate process. So not only is it useful in cases of finding the primary site, but in situations where the primary is unknown, as well as if the patient has distant metastasis. So knowing the primary site will help in determining prognosis and choice of therapy. And I mentioned that the G1 tumors are well differentiated and resemble the neuroendocrine cells from which they arise. They retain high levels of somatostatin expression, and they may secrete hormones, whereas poorly differentiated tumors are less like the normal and neuroendocrine tissue, and they have decreased somatostatin receptor expression. They do not produce hormones, and they have uncontrolled proliferation. So these are some of the characteristics of advanced or poorly differentiated. So poorly differentiated tumors are typically considered to be G3 tumors, and there may be absence of somatostatin receptor expression, and so they may not be visualized by gallium Tate PET CT, and these may be because they have high glycolytic activity and metabolism. They may be well visualized on FDG PET. So remember this: poorly differentiated tumors, FDG PET; well differentiated tumors, gallium Tate PET. We call it a flip. So there may be a flip-flop phenomenon in which the gallium Tate PET CT and PET's FDG PET images are inversely related to each other. Um, G2 tumors, on the other hand, are in the middle of the spectrum, and they can be seen both on the gallium Tate and FDG. So these two modalities are complementary, and please understand the biology of this tumor. It can be extremely aggressive, or it can be indolent. It can be very well differentiated or poorly differentiated, and so the current European Neuroendocrine Tumor Society guidelines say that FDG 18F FDG has a role only in G3 group where surgery is indicated. However, there is no overall consensus on some of these issues. Here is an example of a tumor which has different uh, levels of aggressiveness. There is one part which is extremely aggressive and one part which is very indolent. So obviously you may find that the poorly differentiated tumor is uh, picked up on FDG, whereas um, the well differentiated tumor is not picked up on FDG. So here's the FDG PET, here's the gallium Tate PET, and so you see there are different levels of activity. Here you're seeing a lot of activity, and there is some activity on the gallium Tate, um, whereas you're seeing uptake here, which is much more in the liver compared to this. So it is the same person with different degrees of aggressiveness within the same tumor. Um, and so these two modalities will act as complementary to each other. Um, I want to point out that FDG PET will identify patients with adverse prognostic features, and SUV maximum greater than 3 was the only predictor of progression free interval. This was found to be superior to Ki67 staining, and also anatomic parameters such as the number of hepatic mets. Um, so FDG PET is selectively useful in patients who have poorly differentiated malignancies. Um, and of course, we are going to decide how we are going to treat these patients based on the type of somatostatin receptor expression that they show. I'm going to talk briefly a little bit about some of the false positives. There can be physiologic uptake in the uncinate process. Spleneculi can show uptake, and the reason this is relevant is because a lot of these patients undergo splenectomy. Then osteoblastic activity, degenerative bone disease, fracture, vertebral hemangioma, epiphyseal growth plates, inflammation, reactive nodes, prostatitis, post-radiation therapy, and then of course incidental changes like meningioma. So here's an example. Um, there is increased uptake here, which one would think is pathologic, and again the same high degree of uptake. And then we find that this is basically prominent uptake in the uncinate process of the pancreas. There's no tumor here. Another example here. So here's a focal lesion, high uptake. This person had undergone distal pancreatectomy and splenectomy. So this was thought to be a recurrence, and this is again showing up this 2 centimeter nodule with focal intense uptake on the axial PET CT, and then obviously the differential was spinosis versus is that a metastatic lesion, and so FDG PET shows low uptake. So let's go back to so initially we thought this is on the gallium PET CT. This was thought to be a possible metastatic lesion, and on FDG PET it showed only low uptake. So obviously this was thought to be a possible metastatic lesion, a peritoneal implant, but they did a follow-up study with denatured red blood cells, SPECT CT, and this was found to be a splenule. Now this is an example of a person who has a low degree of uptake in C4. Um, this you're seeing on gallium, there is uptake there, and then this turned out to be a hemangioma, as you can see on the CT scan. Uh, so you have to be aware of some of these variations and false positives. Now, one last word I want to say is that this agent has been found to be useful in many other tumors which have high degree of somatostatin receptor expression. Obviously, pheochromocytoma, paraganglioma, neuroblastoma, meningioma, and then mesenchymal tumors, which cause osteogenic osteomalacia. And it is possible that this agent may become an agent of choice in pheochromocytoma and paraganglioma.